Good evening, everybody, and welcome to Heart, Less Leg, More Hearts peer virtual support group meeting that meets the second Thursday of every month at 6 p.m. Eastern. We bring health and wellness experts to the comfort of your own home to help you be more awesome superheroes. And today is no exception. A dear friend of mine, someone that I trust with my body and physical states. He's been a mentor for me throughout my amputee recovery and journey with a rare vascular condition. Kyle Sikes, who's going to be our presenter today, is a doctor of physical therapy. He graduated from the University of Maine in 2011 with a BS in zoology, which is animal biology, with minors in microbiology and exercise science. He earned a doctor of physical therapy degree in 2021 from the University of New England. He owned and operated a local gym for several years, which is where I met him in the CrossFit space before he started his career in PT. He's competed as an athlete in the CrossFit Northeast Regionals for 4 consecutive years and as an individual and once on the 207 CrossFit 207 team. Kyle does all the things. He loves hiking, running, skiing, snowshoeing, rock climbing, gardening, and carpentry. He has experience in MMA, Taekwondo, CrossFit, powerlifting, Olympic gymnastics, or Olympic weightlifting, gymnastics, sports conditioning, and strength. And his special clinical interests include lower extremity orthopedics, which is why he's great for us amputees, popliteal artery entrapment syndrome, which is like amazing because that's my rare vascular condition, lower back pain, which all of us have, and then sports PT and manual therapy. So without further ado, Kyle, thank you so much for lending your knowledge and your time to help us understand today's concept, which is trying to minimize secondary injuries and just taking care of our bodies in the wake of having a limb amputated. So I know you have a presentation and I will be your maestro. So tell me where and when you need me to scroll,
Awesome.
but the floor is all yours.
Thank you. Awesome. Fantastic. Thanks for the intro. We'll just go to the next one. I'll use it a little bit like slides just for some notes. I'll talk about some things vaguely. How many people are in the meeting right now? We have like
There are four live, and then
Perfect.
we'll have a lot of post watchbacks and also people trickling in.
Okay, great. So what we'll do is I'll go through it rather briefly, and then if people want to ask me more specific questions just about one thing or another, I think that's the way I can be most useful. So one of the risks for lower extremity amputation is that your contralateral limb, the good limb, is at risk of overuse and overuse injuries. That's going to be the big thing that gets better again. It's also going to be compensated use. Your center of mass shifts. Legs are heavy. So if you lose any mass over there, you're going to change the way that you walk. You might not feel it in certain ways, but it will creep in on you a little. Reduce use for the remaining limb on the affected limb. Um, that changes a lot of function. Even if you're trying to load it as often as you can, it's not going to be the same as if you were swinging a leg of regular mass around. So it gets less strengthening from natural motion. So that's something to work on. Creep is something more to think about with postural changes or changes over time. Things that might not affect you right on. It's a little bit like how silly putty works, where tissue is very bouncy, it's springy, it's strong, except if you let it sit still in a certain position for a little while, it'll deform and then it'll stay in that position. So that's something to keep in mind for if you notice changes after 3 years, but you're not sure where they started. A lot of times it just comes down to a tissue property called creep. And upper extremity versus lower extremity risks, they're just different. Upper extremity overuse is really going to take its role, but you'll run into a little bit less as far as shifted center of mass, lower back pain, other compensations that come from just having upper extremity versus a load bearing limb being affected. So this one's just kind of a brief slide. When you're thinking about what your leg has to do for work as defined in physics is force times volume or force times distance. So in this case, we're just going to think of this distance as volume as total work. So if you're doing the same amount of stuff, but you're asking one limb to do the job by itself, force goes up. By definition, work has gone up. Moderating forces and our motor strategies associated with those forces is a good way to prevent injury. So two ways to think about forces on a limb is resting forces and high power forces. If your limb is made to support 200 pounds on average, and it was sharing that job with a second limb, and now it has to do that job all by itself, you're going to choose a different motor strategy to do that task, even though it's the same limb. When a limb is working at low forces, ideally what would happen is the muscles closest to the joint with the most torque would be responsible most of the time. What happens if the leg has to do more force than what it's naturally conditioned to do or what it's ready to do at that particular moment, is it's going to choose a higher force motor strategy. So we're going to use muscles less geared for torque, more geared for horsepower. So if you're thinking about hips, torque muscles that are close to the joint for your hip, glute min is the closest, glute med gets a little bit further away. And then after that, we're starting to look at quads, your IT band, your TFL, and your glute max. The difference is because the glute min and the glute med are very close to the joint, they don't really slide over too much. They don't get in the way of too many things. They have their own problems that happen where they'll get tight in certain ways. But if you have to start using the larger muscle group, like your TFL, glute max, and IT band, that's really made for running and jumping. If you're using that to support your body weight 24/7, you're going to run into an issue with that component. So it's not uncommon that people get things like bursitis, where the IT band slides over the greater trunk on your femur. If your hips are stronger, you don't have to recruit your horsepower muscles as much, and you're less likely to run into some of the issues that get associated with that. Part of that ability to moderate your motor strategy has to do with how strong the limb is. So stronger limbs get to have more choice in what they do. A weaker remaining limb has less choice in what it has to do. Your brain's just going to pick what it can do to fit the task or whatever it demands of you. So whether it's stairs, climbing in and out of trucks, hiking, anything like that, your brain's just going to do what can meet the task. If the limb's running at 90%, it's running at 90%. Some people function really, really well operating at high capacity. Some people need to build in residual capacity. Some of that's going to be a little bit of personal preference. You'll run into that a little bit with back pain too. Depending on what motor strategy you use more often, your brain's going to default towards using that dominant motor strategy. So if the limb is running at high forces, but its conditioning is not up for that, and it's running at 90% all the time, then at rest, you're going to continue to use the stronger motor strategy, which might be the more horsepower motor strategy, not the one that's geared for torque and better for posture and sustained load bearing, standing, walking, things like that. If your brain defaults towards that other motor strategy, you might feel like you're trying to do things to change what you're doing for movement to not irritate a bursa, a tendon, a muscle, or anything like that. But some of these processes run automatically. And to have your brain shift from one motor strategy to another takes training, takes conditioning. A lot of it can happen automatically, but other parts take kind of conscious inhibition type of drills to delete that inappropriate motor strategy. There's some funky drills for it that you can do that are fun once you figure them out. They're a little bit tough at first when you're trying to figure out, how do I get this muscle to relax? How do I get this other muscle to work? But there's things that you can do over time to change that. So like with back pain, people, if you're using the horsepower muscles in your back, the back straps, the ones that are further away from the joints in the back, you might find that standing tends to be much more fatiguing than you expect. And it has less to do with how strong the back is overall at peak forces and just the motor strategy that you might be running at that moment. While the peak force management plays a role like we discussed before, it's not the only thing. On to the next one. So there's basically two ways that people tend to compensate when they're using their leg. You're either going to choose an external rotation strategy from the hip. Your knee is going to choose a varus. So varus just means the knee kinks out, and you're going to get into a rigid foot position. The other one that we'll discuss right afterwards is knee kinks in, hip internally rotates, and you run into an issue there. Your leg has basically two modes when it's operating: shock absorption mode and force production mode. This one right here, external rotation, knee pushing out laterally a little bit, and our foot stacking into supination, high arch position. That one's for force production. Depending on who you are, how your joints are set up, how your motor strategies are set up, you just kind of bias one way or the other. This one, some of the challenges with this one is that your leg's rigid, your foot's rigid. If you're stuck in supination, your ankle mobility tends to suffer. Some of that has to do with some of the bones and how they interact. So if we take our handy dandy foot here and we put it into supination, basically what's going to happen is my foot stacks and it gets rigid. One of the problems of this position, though, is I need to have shock absorption phase. My leg has two modes for a reason. And if I'm stuck in force production mode, not shock absorption mode, when I need to do things like have my shin bone go forward, I have a really tough time in supination doing that. And part of that is if your talus bone here gets a little bit tipped out, suddenly you run into a lot of binding in the joint. And once your ankle can't move, that's a dominant joint for your ground contact strategy. Up chain, you're going to have big effects. So picture if you were walking around in regular shoes and suddenly you're putting on ski boots, you're going to walk different. So a lot of that stuff winds up going up chain. So you'll see it at the knee will kink out a little bit. You'll be loaded on the outside of the knee. You'll run into things like if you go to step off a curb, you start to roll your ankle, you want to bend your knee, but you can't for some reason, and you can't get out of the ankle sprain, you fall, you sprain your ankle. A lot of it has to do with just how the whole chain gets stacked up chain. The external rotation position for the hip, the issue that you run into that if you're in that power position is you'll run into a little bit of overextension, typically at the lower back and at the hip. You'll wind up usually being tight into external rotation because it's not necessarily a choice. It's just the way the leg's faulting. And when things kind of fault out, muscles that aren't being actively engaged, they're not in the proper position, they'll usually just get tight as a compensation. So if you get stuck in an external rotation position, you might run into things like tight hip flexors, tight quads, usually couples with some other motions. We'll discuss that on another slide. So if we go to the next slide, the other way that your leg can typically fault would be internal rotation at the hip, the valgus knee. So knee kinks inward a little bit and your foot pronates. So it goes into this flat arch position. And a lot of it just comes back down to this joint again. So if my arch collapses like so, I get what's called a miter effect from my ankle joint, and my shin's going to torque a little bit. So if you have your arch collapse in, your knee's just going to follow. And you can try to fight that from up at the hip, but a lot of it comes down towards improving ground contact. So things for that is foot intrinsic strengthening, foot mobilization to make sure you can go between pronation and supination. A lot of times joints get stiff. So even though pronation is usually thought of as like weak foot, it could also be a stiff foot stuck in pronation.
Just to also tell people that may not have medical that are watching this, just like what the medical terms mean. Maybe you can show your hand instead of your foot.
Pronation, shock absorption phase, flat arch. Supination, high arch position. So if you've ever been to a podiatrist or just seen stuff on feet, orthotics, anything like that, high arches, supination, low arches, pronation. It's your foundation with the ground. There's a lot of torque that happens up chain. A lot of what can happen with your knee, your hip, and your back starts at the ground. If you have a neutral foot and you're still running the knee and hip issues, well, great. It's one less thing in the equation to deal with. Some of the issues, if you do have flat feet, if you do fall into pronation, if you are stuck in that shock absorption phase, is one, you're going to have a hard time making forces. So whenever you go to put force down into the ground, if you're stuck in pronation, whenever your knee's trying to push with X amount of force, it has to do more work than that because the foot offsets it by being kind of spongy and shock absorbing. You'll run into usual medial meniscus issues, medial meniscus irritation. The compartments in your knee wear a little bit different. Up chain, that internal rotation strategy for the hip tends to be kind of rough on the hip. You can get increased pinching in your hip flexors. The bursa in the front of the hip can get a little bit irritated. And it tends to be just a little bit tough on the hip joint itself. When your hip rotates internally, the joint packs really tight, so it feels stable. So even though the rest of the leg's kind of in the shock absorption phase, the hip gets really, really stable. And suddenly you can walk, move, do what you need to do. Whether or not you fall into one position has to do with just foot structure, hip structure, motor strategies, what's strong for you. Everybody's got slightly different hip angles, slightly different knee angles. And whichever one is just the strongest tends to be the one that people tend to bias.
Yeah, and I think too, for a lot of us that are recovering from amputation, we've had periods of time pre-amputation where we've been disabled or we've been, non-ambulatory or minimally ambulatory or using assistance devices for a long time, where we've built these muscular imbalances, anterior, posterior, front and back, and also side to side, and atrophy of the intrinsic foot muscles. I did want you to explain, just because it was eye-opening to me, Kyle does work on my legs, and it's really, I think, the reason why I haven't needed surgery in several years. But when you talked about intrinsic foot work for folks that are watching, can you kind of explain the foot roller thing that you recommend for people that I always use on my residual foot, and also some of the stem techniques or some of those intrinsic foot techniques that you mentioned, because they've really been a game changer for me. Like my toes, as when he saw me, were curled up on my residual foot from the overuse and the contraction and tight stiffness from all of the atrophy. And now, after just working with him in a handful of sessions, my toes are still completely straight. So I'd love for you to share with them some of those pieces.
Sure. So when you're looking at how feet function, a lot of the times feet get stiff. Sorry, my dogs are barking. Let me just get this door open.
Yeah.
So one of the ways that feet function is usually if you're running the foot issue, the foot's going to be stiff in one direction or another at one of the joints. You have a lot of surface area in your feet. Your feet deal with very, very high forces, and that's distributed across a lot of surface area. Some of the problem though is all that surface area that's made for shock absorption, transmitting force and stuff like that can also be surface area that gets stiff. And just moving around, walking around, you're going to walk around that stiffness. You're never going to notice it. And the joint will continue to stiffen to whatever position that is working for you at that particular moment. Some of these things that we're talking about with hip strategy, knee strategy, foot strategy, you might find for some period of time you're running into one movement fault and may shift to another. So for a foot, one of the things that we did that's a great cheat for making your foot more active is just electrical stimulation. So you can pick up a TENS unit. Most TENS units have an NMES setting on it. So NMES, neuromuscular electrical stimulation. And you can just put it over bottom of your foot, inside of the foot, outside of the foot, anywhere where if you pull up a map of foot muscles online, the pads are usually pretty big, put them over it, stimulate the muscles, and suddenly your brain will become more aware of, oh, I have muscles down there that I can use. We spend a lot of time in shoes. We don't get the feedback for our foot that our brain typically needs to stay aware of how the body part is. And just like any trade skill, motor skills tend to degrade and you'll forget how to use your foot. So some other things that you can do that help is just regular strengthening, move around barefoot in a safe environment if you can do so, and try to move your toes. A lot of people just don't move their toes very often, so their brain forgets how to do it. Some basic drills that you can try just to see if you have good motor control over your foot. So you can do big toe up and little toes down, and you can see if you can do that sort of opposition. Or you could do big toes up, little toes up, big toe down. Just kind of pick one of the confirmation, whether little toes are pushing down or lifting up.
All of us are wiggling our toes under our desks right now.
Yep. And you might be good at one. A lot of times people are really good at the big toe up and really good at the little toes down. And the way that they're really good at little toes down is they try to push from the tips of the toes. But while you're trying that drill, if you feel like you're pretty good at pushing down with the little toes, try to push just from the base of the big little toes and not from the tips. And then when you try to push down with the big toe and lift up the other ones, try to push down just from the base of the big toe and not from the tip.
You feel it more in like your shin or your lower ankle than you do in your foot.
Yeah, and the reason why is the muscle that drives the tips of our toes is based all the way up in our shin. The muscles that drive the base of our toes tend to be more in the foot. And the problem with that is a lot of the tendon, the nerves, and the blood vessels that go down to your feet trace right next to the long tendon that controls the tip of the toes. The tip of your toe is made just for that last part where you go to leave the ground and you just need a little flick. So it's a horsepower muscle. The other ones that are here are shorter, they're closer to the joints, they provide more stability to the foot, and they tend to be more of a posture torque muscle. So kind of that theme that we talked about before, you're going to choose a motor strategy depending on the force that you are. And most people, no matter what, tend to use the tips of their toes way too much. And they'll kind of wind up in this digitally clawed resting position.
Mm-hmm.
Some of the problems with that is depending on who you are, what's your age, what's your medical condition. Toes being up like this is usually an issue. You can get increased blisters. It's a dark, moist, damp space. And what you don't want to deal with is risk of infection, especially if you have anything going on with your immune system.
And also as a plug in there for anybody that is diabetic that's watching this, that is also an amputee and has a heightened risk of the other leg degrading just because of their pathology, making sure obviously routine podiatric care, with a podiatrist and foot doctor is important. But I would really encourage people to also have a biomechanist, a physical therapist that they work with on really just feet mechanics, because I didn't realize how much there was to know about these tiny intricacies that will genuinely preserve your skin integrity and your quality of life until Kyle ran through, and I was just bewildered as a physician assistant that had been an amputee already at that point by, for 5 years. So find somebody that can talk to you about the remaining foot that you have if you are a single leg amputee, to make sure that you really optimize the way that it functions, because that lack of function will augment, as you said, your nervous vessels, your blood vessels, and the skin integrity. So it's really important for especially our diabetics too.
Yep. And if you're looking for just a really basic drill to strengthen up your feet, just doing towel scrunches is pretty good. So end of the day, if you take off your sock, you can grab a towel, or you can just use that sock that you took off. Just try to pick it up, put it down, pick it up, put it down. Try to use the tips of your toes at first, and then try to use the base of your toe. Try to push it forward, try to manipulate it. Try to do it with just some toes, try to do it with just your big toe. Just kind of use your foot like you'd use your hand. Just that's the way that your brain learns. It tends to learn through exposure. And the more exposure you get it, the better off you're going to be with your situational awareness with your foot. One of the
Yeah,
things
so
you can do.
me too, and you have two kids. Kyle has a new baby. Is
Yeah.
they're so active with their feet, and I feel like we lose that over the decades. And you're right. I mean, all of the adult feet that I see in the yoga classes I go to, they're like preformed, immobile little walking pegs.
Yep. And even stuff like bunions, where the first spray kind of kinks in, a lot of that just comes down to what's going on here at the midfoot. So a lot of times, let's say you overpronate, so you go into shock absorption phase too much. When you go to leave the ground, you're more likely to leave the ground with that toe getting met with a little bit of valgus force, versus if your foot can stay nice and rigid and strong, then the toe just leaves the ground like so. And the way that you put the force through the bone dictates how the bone grows. So if you're running into things like bunions, you can't make bunions go away unless you get it surgically worked on. But one thing that you can do is you can make the first digit on the race sit a whole lot better, and you can slow the progression or the irritation that's occurring in a bunion. The other way to make your foot just function better with foot intrinsic exercises, besides opposition ones for pushing down, lifting up, pushing down, lifting up, you can do toe spreads. Get your foot mobilized. So if your foot is rigid and is stuck in a position, it would be kind of like trying to strengthen your arm when your elbow is stiff. It's really hard to make the rest of your shoulder function well if you can't bend your elbow enough. Same thing goes on for the foot. A lot of times, if you're stuck in shock absorption phase, you're going to be using the muscles that are typically used in shock absorption phase. A lot of times, if you're stuck in rigid high arch position, same deal. You're going to be stuck using just the muscles for that. And that is the best foot roller in the world. And I don't think the company makes it anymore. So if anybody wants to find them, I
Yeah.
haven't been able to find them. Yeah.
Kyle told me about this one.
Yeah, I think it was the company that made the stick, and I haven't been able to find those guys online either. It's called the Trigger Wheel. They're great. You can usually find them on eBay or Amazon, and it lets you get in between the tendons and the deeper surfaces.
Yeah.
Because
Just have a towel. You might sweat a little.
yes, that you will find very, very sensitive trigger points with that. You're not necessarily doing damage. If you feel like you're pushing on something that's super duper tender and you need someone to tell you whether or not you're pushing on something that's appropriate, check in with a chiropractor, PT, massage therapist, athletic trainer, anybody that can just tell you what's going on in your foot. Just like the joints can get stiff, all the tendons can get stiff. Picture how stiff you get if you go on a 3-hour car ride, then you go to stand up. That's how your leg feels. That's how your back feels. That's how your arms feel. Well, your foot's usually spending way too much time in a shoe. It gets way too little strengthening, way too little feedback, and it's very easy for the soft tissue to get stiff as well, which if you're trying to do foot intrinsic strengthening and it feels like it's just an act of futility, sometimes just mobilizing the bottom of the foot can help. The trigger wheel's great, but if you're looking for something more gentle, a golf ball or a lacrosse ball tends to work pretty well, just gentle massage. If you're a diabetic and you have neuropathy and you can't feel your feet, you're best off to go and consult someone like a physical therapist, a podiatrist, or a chiropractor that can work on your foot in a way that's a little bit safer. Or if your skin integrity is in question, just be careful with the self mobilizations, things like that. A lot of it just comes down to just take care of your foot. Don't beat it up more than you have to, that type of deal. A lot of how you manage your feet, though, will dictate how your knee feels, how your hip feels, and how much more stable you feel with the ground and what your upstream strategies.
Yeah, and I think too, like just looking at your feet, they tell typically a good picture. I mean, when Kyle did his first analysis on me, and if anybody lives anywhere drivable to Southern Maine, you got to get to see him, or New Hampshire even. We can talk about how people find you at the end, but within minutes, he was able to literally regurgitate to me what the patterns of my movement were just in looking, and what upchain pains I was dealing with in just the way that he was observing my foot. So if more of us could be employed to be proactive in this way, rather than things start breaking down and then we seek help, if we look down and we look and see something's deformed or something is claw-toed or something is wonky, or we're feeling a repetitive, issue in a hip or a knee or a lower back, there's typically an adjacent issue in another area. So seeking out PT is an incredible addition to your medical team. So many amputees that come my way, and I'm sure you guys on the call can attest to this. You were told probably by your physicians that you don't need PT till you get your leg, right? But what an optimal period of time while you are waiting to strengthen and to optimize the remaining foot and leg that's going to be taking all of this additional force. And it's a huge missed opportunity in almost every single person of the hundreds that we've helped, where they are withheld a referral because there's a misconception in medicine that they need to have their prosthetic to start working with PT. So I just wanted to get that out there for anyone watching, that if you're thinking of getting PT, the answer is always yes. It doesn't matter what you're waiting on. There are things that they can be helping you with like this.
Yeah, prehab. You're getting ahead of the issue, where if you know that you're going to be working harder in this way, and you know that you're at increased risk of injury, it doesn't hurt to get a movement analysis and to get some exercises, to get some joint mobilizations that might help you. Most people don't move 100% perfectly, and the faults that you have going into an injury are usually the faults that you're going to have coming out of it. So you might as well get ahead of it and try to make your assets as strong as you can before you have to use them for daily life or extra tasks or whatever you want to do. What's on the next slide? I don't even remember what was next. Oh, okay. So this one, hip drop. So when you're standing on one leg, the side of your hip has to work really hard. So glute med and glute min, they're working at their most when you're standing.
Your butt muscles, for those non-medical, they're butt muscles.
Butt muscles. Here, I got a little thing I brought in the room just for this. So it'd be these two butt muscles on the side of your hip. So whenever you go stand on one leg, your hip just wants to fall like that. So it takes work from glute med and glute min to hold your hip still. Whenever your hip kind of drops when you go to stand on the leg, they'll call it a Trendelenburg fault. So if you go to see a PT and they say, oh, you have a Trendelenburg hip, it just means you have a hip drop when you stand on one leg. One of the things that tends to happen if you do have a hip drop, which you might not have one when you're not tired at the beginning of the day, but you might have one at the end of the day, or you might not have one before an 8-hour shift to stand on your feet, but then by the end, suddenly both hips have it, and they didn't before. The way that we tend to compensate for hip drop is we tend to arch our back a little bit more. That changes which fibers are lined up. Most people tend not to mute their hip and round their hip forward into a posterior tilt to compensate. Most people go here as they get tired. They arch and arch and arch and arch. A lot of that just has to do with you're tired, you're uncomfortable, default protective mechanism is go here. It's just a natural reflex. It's just spinal extensor reflex. It's one of the first things that we learn to do when we're baby developing, and then it sticks around during almost any period of stress. It's part of why people, when they get stressed, they get back pain. When you go into extension, the other muscle that couples with it as a cause and also gets recruited more as part of that position is your hip flexors, your big hip flexors, so as the ones that attach to the front side of the spine and the one that anchors on the inside of the hip. It's really two heads of the same thing. They run down, they connect to here on your hip. And they start trying to supplement what these muscles are supposed to be doing. Problem is they don't do a very good job at it. And usually when you're trying to use a muscle inappropriately, it's going to run into some issues. So you can run into some bursa issues as you go into the arch position, interior to tilted position. Every time your hip drops, you're more likely to pinch the capsule or the muscle where it sits right on top of the joint in the capsule. There's a bursa sac here, so it's a lubricating sac where the muscle runs over the bone. That can start to get a little bit irritated. Usually if your back is arched more, you tend to go into the internal rotation fault. So that draws the hip flex around the corner even more. So now you got this muscle, it's getting twisted, it's getting pulled, it's going extra far, it's toned up all the time, trying to do more work. Part of the problem is when you're using your hip flexor more to try to compensate for this, your leg can't go behind you nearly as far because that's what the muscle does. It pulls the leg back forward. So you'll run into inefficiencies with gait, or you're going to try to walk around the tightness in that hip flexor, and you're likely to do a little bit of a heel whip when you go to leave the ground. So your foot has a little bit of a spin. So if you're walking around, you start noticing like the front of your shoe wears out quite a bit, or if you're dealing with bunion issues, sometimes going up chain and changing the way that you recruit here, how you hold your pelvis, and how your hip flexor is working can affect how your foot works. Things bounce back and forth. A lot of the loops that you run into for biomechanics tend to be a little bit of yin and yang. So this causes that, and that causes this. Where do we break the cycle? And it's like, well, wherever you can. For the most part, strengthening glute med and glute min. So sideline straight leg raises, clamshells, side steps and bands, doing that routinely. That's good for just about everybody. If you're working with an amputated limb, then it's much more so that you need to keep your hip strong. A lot of what they would get for natural strengthening for moving your leg around, it's going to happen a little bit less on a lighter leg, so you have to supplement it. Making sure you can do so with proper foot orientation, whether it's an internal rotation strength or external rotation strength, kind of just depends on where you're strong. You would just want to strengthen things that are weak. You might have a muscle group that's really strong for a period of time. Lifestyle changes, workplace ergonomics change, what you're doing for your day-to-day changes, and your strength changes as a result. So a lot of just preventing injury, it's a constant thing. Might feel tedious, but if you don't like getting hurt, well, then being on top of it feels well worth it.
None of us are growing our legs back anytime soon, so we got to take care of the stuff that's still around.
Absolutely. A coupled fault that tends to happen when people have a Trendelenburg drop is, I'll just show you because everybody tends to stand this way. It's just a natural way that people load up their legs. If you watch somebody just stand on one foot for a period of time, they go from being here to shifting their weight a little bit to doing this thing. And they kind of push their hip over and back as they arch. So watch people are standing in the grocery store behind their cart, and they're usually here. So
I do that every day with my native leg, and my prosthetic one popped up. Yeah.
Yep. I'm going to stretch my glute med and glute min. I'm just going to hang on them instead of having them squeeze. And now I'm going into spinal extension. My back will be sore later if I do this long enough. My hip flexor is more engaged. It's getting pulled around the corner. It's sitting against the bursa a little bit harder. So if you got to strengthen anything, strengthen these back fibers and the glute med and glute min tends to help. A lot of the way that also plays into it is when we extend, the rear fibers are now up, everything kind of moves, and it's just not as strong back here. You have to use glute max, and that's a horsepower muscle. We want to strengthen up our torque muscles. So start trying to catch yourself doing that. You can make your hip stronger just by not doing it. If you get rid of it, you hold yourself neutral, you work through the burn, or you go and sit down once your hip's tired instead of trying to compensate. That tends to help quite a bit. So that's a couple of fault. Start noticing if you do it, and then watch everybody around you. Everybody does it. It just beats up legs, beats up hips, beats up backs. You don't need to do it. Two common postural faults: upper cross, lower cross. They tend to happen at the same time. Spine's balancing act. We already talked about how the leg's a little bit of a balancing act. Same thing happens with our spine. Upper cross, if you spend a lot of time at a computer, we kind of wind up here. So we go into a position where certain muscles tend to get a little bit tight and overused, and certain muscles tend to get inhibited. A tight muscle isn't necessarily a strong muscle. The tight muscle is just tight. I can put force through it, but I can't generate force. So it changes your motor strategies overall, but it tends to beat up any joints involved. So if you have upper cross, tight pecs, tight upper traps, tight levator, your rhomboids get a little bit dominant. It just has to do with how people tend to orient their shoulder blade. Things that get weak are muscles that are kind of awkward and weird to strengthen, things that people aren't usually aware of. So like serratus anterior, it's a little fishgill muscle, that G.I. Joe muscle where they paint the extra lumps on the side of people's rib cages. That is a muscle that controls your shoulder blade. If you wind up here, the muscle's just off. Deep neck flexors, there's a little muscle right here at the base of your skull called your deep neck flexor. It's basically the hip flexor for your head versus hip flexor down at your hip. And when that muscle gets lengthened, we tend to wind up here. It gets weak easily. It's easy to strengthen. Chin tucks, head lifts. You can look up those exercises online. They're strange exercises. Careful not to overdo them. Consult with somebody if you have to. Keeping that strong tends to put people here a little bit more, and it tends to help with a lot of the upper cross stuff. So if you can just strengthen your deep neck flexors, look up videos online, do it safely. a lot of what happens with those postural faults tends to go away. It's also good for your lower back. Spines couple. What your neck does tends to be what your lower back does. So if you're forward with your head, you're going to have more curve on your spine upstairs. And as a result, you're going to get more curve on your spine downstairs. Lower cross, similar thing. Muscle groups get tight in a quadrant pattern. So if I slice my hip this way, I'm likely to get tight in my hip flexors, tight in my quads as I roll forward. As a result of this overextension, my lower abs get a little bit weak. My psoas, that one gets a little bit weak. Got a hard time controlling posterior tilt. Lower back gets tight, glutes get weak. That tends to be the pattern of lower cross. You can stretch your hip flexors all day, but a lot of it comes down to stretching, strengthening, mobilizing, and motor strategies. Muscles that are tight, a lot of times they're just toned up to try to offset the postural fault, and you can stretch them a bunch. Doesn't necessarily make them looser. Sometimes they need a little bit more. Sometimes it can be strengthening. Sometimes it can be eccentric control. Sometimes it might just need to be mobilized manually, so it can solve someone. Hamstrings are weird where they play in that. So when your pelvis falls forward, your body thinks that you're falling a little bit, so it tends to just tone up at the hamstring. So you get this strange thing that happens where your hamstring's really good at staying tight in a certain position, but again, tight isn't strong. So then if you try to do hamstring exercises like leg curls, hamstring, they feel really, really difficult. But then if you want to bend forward to touch your toes, you can't do that either. And it's just because the muscle's tight. It'll transmit forces great, but tight muscles are a bit tough to work around. They're rough on the tendons because the tendons need to have a break. If the muscle's tugging it all the time, you can run into a little bit of tendon pathology, whether it's full-blown injury or just irritation. Kind of depends. But that's just the common postural fault pattern. A lot of people have it. A lot of that just comes from chairs. It's one of those things where if you have it, it can get exacerbated by dealing with limb loss. And then let's see what we got next. I had one more. Oh, heel cords. Yeah. So calves. Going back to ground contact, one way that people tend to supplement their ground contact is we use our calves. It's closer, it gets feedback, it's a bigger muscle. I can see it, I can strengthen it. It runs at an angle where it puts you into supination, so shock absorption phase. If you think about what your calf's made to do, it's made to help you go forward. And so it's going to put you into the force transmission position. Part of the problem is it's a really big muscle group and it's shaped in a way where it has a lot of torque on the heel. And if your heel cord gets restricted, it's going to dictate a lot of what happens at the foot and a lot of what happens at the knee. Most people have tight heel cords to begin with. A lot of that has to do with we sit a lot. When we sit, our feet are pointed. We grow into that position, we get tight. We do that all the way from kindergarten all the way through high school. And we grow into shortened heel cords. Part of the other thing is most shoes have a heel lift, whether it's a hiking shoe, running sneaker, a lot of them have like a 12 mil rise in it. A lot of that is to accommodate tight heel cords, but part of the problem is it perpetuates tight heel cords. If your heel cord is tight, it can be for a couple of reasons. It could be short because you grew into it a little bit short, or some of it could be that it's overtoned because it might be one of your strongest muscles in your leg. For a lot of people, it is. Your brain's going to default towards the strongest asset for staying stable when you have to walk, run, jump, stand, sustain. And you're likely to just keep contracting that muscle, even when that muscle is supposed to relax, to let your shin track forward. Some of that could be based on feedback from the joint. Some of it could be based on feedback from the tendon, just motor strategy that's been picked over time. Maybe the tissue is restricted. If the tissue gets tight, it's going to try to just stay in that position. Whenever you try to pull it out of it, it'll fire off. There's certain receptors that play a role in that. A lot of times when tissue gets bound up, the receptor can get overstimulated. You can carry too much tone, then it stays tight. The other things that happen is because your calf is so big and strong, you tend to overpower the foot. So it'll run into a mixed pattern of what I had discussed before, where you got shock absorption phase going into pronation, and then you got force production phase going to supination. You can have both problems happening at the same time, where the back half of the foot gets stuck into force production phase, and then the front half of the foot gets overpowered and goes to shock absorption. And then no matter how you move, you feel a little unstable. If you run into plantar fascia issues, you might run into bunion issues. The heel cord's always tight. Issues tend to mix and then they shift over time. A lot of it is just kind of keeping up with the situation, just identifying where the fault is, trying to figure out what piece of tissue might be involved in what way, and giving it the thing that it needs in order to do its job a little bit better and to take pressure off some of the joints that tend to wear. So if you have really tight heel cords and you're dealing with this first ray kinking in, there's usually a relationship. Stretching your heel cord is a good place to start. So just standard calf stretches, be gentle. It's easy to overpower the muscle. If you're getting pinching back here, there's some other things that can happen to how the joint seeds. Yeah, those tend to be just kind of the big things to be aware of. It at least gives people hopefully some things that you can look up online. Look up any of these faults that I mentioned, any of these strategies that I mentioned on YouTube. There's a lot of good PTs on YouTube that can discuss the stuff in much more detail and more thoroughly than I can. And if you find a good PT, it's one of those things where just establish a good relationship. A lot of states have direct access. For most carriers to cover going to see a PT, they need a medical referral. But in most states, you have the ability to go see a PT directly if you want. If it's just for something where you don't think that if it's prehab and there's not a diagnosis throw behind it, it's still worthwhile just going to see somebody, get screened, get strength, and get a sheet of exercises that now you can use that forever.
And I've also used the diagnosis because medical clinicians, in order to refer you, need a diagnosis. And if you don't have an active diagnosis for rehab, you can think of things like deconditioning. Deconditioning is an acceptable diagnosis for management and evaluation for PT. So most of us have reasons, but think of making sure that your providers, if you ask for a PT referral and somebody is balking about it, for me, as your advocate, it's sort of a red flag because that you would think that they would want that for you. So just think about the care that you're in, and you shouldn't have a problem gaining that access. And if there's financial barriers to people obtaining the type of physical therapy care that they need, our organization at Less Leg More Heart is always here to help amputees navigate that. And so you always would reach out on our amputee in need form on our website for us to help you. Before, Kyle, I wanted to just talk really quickly about insoles. So diabetic custom insoles from their physicians, but us non-diabetic people, we're just out on the market trying to figure out how to reduce ground force. And, for us that have concomitant knee injuries or back injuries and want to just take some of the discomfort around walking, are there insoles that you recommend? Are there things that people should or shouldn't look for when they're just out there trying to find an insole? And how important do you think they are?
Yep. So that actually supplements really well off that heel cord slide, because one of the easiest ways to get your heel cord to relax is to make your brain perceive your foot as stable. If your brain thinks that your foot is unstable, it's going to tighten up your heel cord. If you can get an arch support underneath it, it'll do you wonders up chain. The two brands that I like the most are A-Lines and Superfeet. I wear A-Lines. They make them in New Hampshire. Their website's a little bit confusing to navigate. They've got 4 products. I like them because they support the front of the foot. Your foot has 3 arches. Geez, has 3 arches, 1 in the forefoot. There we go. That's where the slip came from. Not all arch supports go all the way up to the front of the foot to support that 3rd arch. Superfeet tend to get better reviews from clients. The A-Lines can be a little bit rigid, a little bit uncomfortable. They take time to work into. The Superfeet are a little bit softer. The downside of a soft orthotic though is it's not going to last as long. So a lot of Superfeets wear out after about 3 months. A-Lines last much longer. I have a pair that's almost 10 years old. I probably should replace it, but it still does its job just fine. I tend to stand on cement all day, so I like a more rigid orthotic. That one makes my knees not ache. If you get the Superfeet, they're moldable. Don't mold them. A lot of times if people throw them in the oven, they go to stand and mold them, then they just mold it right into the fault that they have. It feels a little bit better under your foot, but now it's not doing its job. If your orthotic wears out, just get a new one. If you do get an orthotic and you try it, start with really, really short wear times, like 15 minutes tops. And you might find the bottom of your foot cramps and is sore for a couple of days, like it got a workout. And part of that is because it did. A lot of putting your foot into a good position allows you to use your intrinsics that you wouldn't otherwise. If you picture out intrinsic muscles feeling if it's stuck into a position that it doesn't like, if you ever played a game of Mercy where suddenly someone gets your arm cranked just far enough, suddenly all your strength goes away. Same thing happens at every other joint, every other muscle in your body. It's called arthrogenic inhibition. When a joint gets cranked towards its end range, part of the way we protect the joint, ironically, is we shut down force production across it. Sometimes that puts you in a position where you have to say mercy. Sometimes it puts you in a position where no matter how much you try to squeeze the muscle, you just can't find it. Then if you get into a better position, suddenly your foot is much stronger and you can start using muscles that previously weren't accessible. So that's kind of where I'd go for orthotics. If you have diabetes, definitely talk to a podiatrist. They will set you up pretty well with it. The off the shelf ones, the A line is the best one I found for off the shelf though.
And I've used his, like he recommended that to me a couple of years ago. And they sent me a trial of each of their types. And I don't like, as soon as I get a new pair of shoes, my regular insole from that shoe gets taken out and I put the other one in. And I have noticed a significant improvement in my knee and my hip and my back in wearing those the last couple of years. So if again, any amputee from the US is watching this and they want to try A-line and it's out of their price range, reach out to us. I don't want people suffering if it's a financial barrier. Thank you for clarifying that. I also wanted to talk about briefly upper extremities. I know a lot of us that come to these meetings are lower extremity amputees, and I know for me personally, and I don't know you guys on the call if you have anything similar. I was on crutches for a long time and mobility equipment a long time, and I was in a wheelchair a long time. And so my shoulders, I've had issues and tears and rotator cuff things in both of my shoulders. I have refractory lateral epicondylitis in one of my elbows that's needed like stem cell injections. My grip has been challenging because of all of the work that was done for years on all those mobility aids. And what I would say, I just wanted to touch on the concept of upper extremity strain when it pertains to mobility stuff. For me, in the wheelchair position, it's a constant push. Your pecs are tight and your back is weak and rounded, and you're just always forward pushing. And it's the same position for people that are transferring a lot. You're doing all this push work at the front. So for people that are in a wheelchair or are constantly transferring, giving attention to mobility and stretching of the front and strengthening of the back muscles is really, really important to keep your shoulder orientation appropriate so that you can avoid or less progress injuries. Is there anything about that concept in terms of that position, Kyle, that you would add to that?
Yep. So 100% on that. That upper cross faults, like you said, stretch your pecs. Lesser a muscle that's easy to overlook that also pulls you in that position is your lats. So stretch your lats. The way it connects to your shoulder can pull you forward the same way that your pecs can. A lot of external rotator strengthening. So a lot of exercise where you're taking bands, weights, and you're pulling away from midline. You really want to strengthen your external rotators because you only have two teeny tiny muscles that pull you this way, and it's just the two muscles that make up the back part of your rotator cuff. Nothing else pulls you in that direction. They're not big. If you compare them to like a pec, pecs are pretty big. If you compare them to a lats are huge. And then your infraspinatus and your teres minor, they're just little. Teres minor is like 2 fingers wide, goes up, supports the shoulder, and then infraspinatus is probably the size of your hand. And that's the thing that's supposed to help pull you back for all those motions. If you get that linkage nice and strong, a lot of the bigger muscles tend to help. Look up lower trap and mid trap strengthening. It's slightly different than rhomboids. It has to do with how the fibers run at a certain angle to your shoulder blade. Oftentimes you can be really good
about back here, guys.
Yep. Oftentimes you can be really good about pulling your shoulder blades together, but you could just be strengthening rhomboids and you can still have some more shoulder issues
Rhomboids
because
are back here too, guys. He's talking all in the middle.
you can be strengthening those, but there's another muscle group that layers right on top. And making sure that your lower traps are just as active and strong is important to have good shoulder mechanics. And your shoulder works with a lot of the same kind of paradox yin yang cycles that the lower extremity does, where once one fault happens, it causes another fault that perpetuates that first fault. So breaking the cycle can be a little bit tough. But a lot of times, if you can find the weakest link in the chain, either strengthen it, mobilize it, do whatever it needs, things tend to get a little bit better.
One of my easy references was I would always do motions up here when I was pushing or when I was doing things. And it was because I had weaknesses in the back, external rotators, like you said, in mid back. So if you guys are finding in your assistance devices that you're transferring or whatever, and that space between your ears and your shoulders seems to be getting smaller when you're doing those repetitions of what you're doing, recognize that is sort of a big sign of the strength that you need to pull into those external rotators in your mid back, and really give some attention to those areas on a repeated basis to build those up. The other thing that I hinted to was elbows. On all of our crutches and our walkers and our rollators and all of these things, you have chronic repetitive stress with grip. And that burns out a lot of people's elbows, tennis elbow. And it's a really hard thing to get away from. It's really nagging and gnawing. And there are rehab things you can do for it. But I would say proactively, if people foresee that they're going to be on crutches for a while, and that's everybody that's an amputee, you will either be on them for a while before you get your leg, or you will be intermittently on them for the rest of your life when you have tough leg days. You should consider an investment or working with an organization that can get you the ones that have hydraulic in them. There are side stick Canadian forearm crutches for those that are appropriate for that, which not everybody is, that actually have a dampening of some of the ground force reaction that goes through them so that you're less likely to have those types of repetitive strain injuries. But even using those, I still had some challenges and I didn't get into them until later. But taking care, I think the big take home here is taking care of these things, your elbow and your shoulders and your back and your hips and those and your feet. If you could really focus, like, what's an honest time frame, Kyle? Like if you told the average person what you don't have specifics about, an amount of time, X days a week, that they really should be, invested in their recovery and prehab movements that we're talking about, what would you say would be a good starting place for people to give attention to these areas at home?
3 times a week. If you're doing like a Monday, Wednesday, Friday split, keep the weekends to yourself, and you get a good routine. You put in about 30 to 60 minutes each of those days. That's usually enough to take care of yourself. You
Yeah,
might find that it shifts day to day. You might have a different routine for each of those days, but that's a decent gym routine for most people.
honestly, guys, I have a basket that's next to my desk and it has bands, it has the foot roller, it has a lacrosse ball, and it has, I have a foam roller, I have a massage gun, and I have a stimulation unit. And every day for 15 minutes, my goal, and I don't do it all the time because I have a 3-year-old, but it's that for 15 minutes, I do a thing for one of those spots to help me be better the next day. And if you can just work that little time, even if you're watching TV at the end of the night, you could roll that foot or you could get that roller out, So think about the tools that are inexpensive that you could add to your home to make these types of things a priority for you. And again, if there are challenges funding it, reach out to us. The other one I wanted to cover, and I know we're running short on time, was supplements. People spend egregious amounts of money on things that are supposed to improve their quality of life. And some I agree with, and some I think are bogus, and some I'm up in the air. And so when I think about joints and muscle challenges over time for people in this demographic, I think about inflammation and I think about blood flow. Are there any things that you have found anecdotally or even professionally that are worth at least a look into for folks that have inflammation or blood flow? Like for me, I'll just say my routine is I take fish oil, 2 to 3 grams of a high quality fish oil every day. I take beetroot, so I have beetroot powder for blood flow, and I have amino acid blend that has like nitric oxide in it. And then sometimes here and there I'll take turmeric. But are there any things additional to that, Kyle, or any knowledge that you have on your own personal athletic journey and what seemed to help keep some of that inflammation better?
Yeah, those fish oils tend to be something I see that's very common. A lot of people respond well to it. People can be prescribed it for different reasons. Joint supplements aren't a bad idea. So like chondroitin, anything that's basically made up of cartilage, if you eat it, it's a better building block
Like
for your
the
cartilage.
glucosamine thing?
Yep, just glucosamine. They're putting it more into sports supplement strengths now because you want to take care of people's joints. It's not just about protein and BCAAs. A lot of it just comes down to it's really hard to eat a well-rounded diet. And if you feel like you're going into a joint issue and you can provide more joint-specific nutrients, then that tends to help a little bit. Um, yeah, the beet juice supplement, you can find other foods that are high in, I think it's arginine is what you use to promote blood flow. I think you cleave arginine to make nitric oxide for vasodilation. Trying about foods that are high in arginine that aren't beets. Nothing's really coming to mind at the moment. If you
We could
did,
Google high
have to,
arginine food.
yeah, I mean, you could look it up. I'm going to guess beets is probably listed as one of the high ones on it. If you did have to, I'm not really good at supplement questions, unfortunately.
That's okay. I was anticipating it would be a riff anyway. But the other thing I wanted to ask, you're such a wealth of knowledge, Kyle, and you have personally aided me in my journey and so many other people. And where is your regional practice? What areas do you serve? How can people find you? Do you do things remotely? like tell people how they can find you.
Yep. I can travel over Maine and New Hampshire. I do travel training. I'll visit people if they need to be visited. I'll meet them at a central location. I try to put things together at local gyms every so often, so I'll pick a day a week. I'll be at that location. The easiest way to get a hold of me is I'm at Greater Springville PT in Springville, Maine. We're accessible off of Route 16 in New Hampshire. I think that's the right one, and off 109 off the Turnpike in
Awesome.
Southern Maine. Yeah.
And then, so I think the take homes that I got for you guys are find a PT and don't wait for your leg. Get into PT as soon as you can, or if you don't have them now, do it anytime, all the time. It's always a great idea. Focus strengthening your glutes, your butt, your hips, and your mid back and external rotators, and probably your grip, your forearm extensors. Those would be good like accessory works that you could do, and you can Google anything on YouTube these days to find out what those exercises are, and then to focus some real intentional time a few days a week on mobility, stretching, and some recovery work. Those were the major take homes. Does anyone here that's present happen to have any questions for Kyle before his brain goes offline?
And I did want to mention something about diabetic neuropathy in feet.
Okay.
Even if you have neuropathy, you can still benefit from a lot of the foot exercises that we talked about. The big thing is if you have neuropathy or impaired sensation in your feet, be very protective of your feet. Make sure you're working with a professional to keep your feet safe, especially if you're thinking about doing anything like barefoot training, anything like that. Do it in a very safe, controlled setting, because that's one thing where if you can't feel your feet, risk of injury is very, very high. You don't want to run into an issue, but you'd still benefit from it.
Yeah. Yeah, great point. And you had a question?
Just a couple of comments. So when the feet are one of those things that really, I'm a lower leg amputee. The good foot that's left, I feel a lot of pain in. There was, especially in the morning after waking up, right? So moving around, trying to get to the bathroom, standing up on the one foot, you're putting the entire weight of your body on that one foot. So I find that it's better to put the shoe on and help protect that personally. But yeah, I can see some of those things could help, like you were saying. So I do wear the shoe insert, which does help a lot too. Right now I've got a gel one, so I'd like to look at your A-line recommendation. That sounds interesting. Those crutches you were mentioning, like the forearm crutches, I found were better than the ones underneath the armpit, right? The one that I found was about $250 called the Ergo Bomb, and it had a nice shock absorber both in the palm and in the stick. So it puts
that's
down
like a third of the price of the side sticks.
Yeah, it's pretty nice. So and that was recommended to me by another amputee, and I picked that up almost right away.
Ergo Bomb.
Ergo Bomb, BAUM, and I found that at online at Amazon or something. I think they see it here at Target too. I did fall and injure my elbow. So this is where I'm coming to the comment here. So my doctor years ago prescribed and said, or at least diagnosed and said, well, you fell on your elbows. Now you've got a lot of pain in your elbows, and I have injury-induced arthritis, right? So she's saying that I'm arthritic in the elbows. And ever since, this has been probably 15 years ago, I felt intense pain when doing exercises. I did the rubber bands. I got frustrated with the bands at home, trying to strap it on a door and try to do these exercises. I said, forget all that. I joined a gym, but there's still a lot of strength exercises that I'm doing where I feel intense pain in the elbow.
Is it more outside or inside of the elbow?
I think it's on the outside of the elbow. Yeah, outside of the elbow. Yep. So one of the things, there was a point at time where I couldn't even straighten my elbow. It wouldn't open all the way. And for me, reducing that inflammation was huge. That was really important. And I had watched a PBS special on the inflammation effects of CBD oil. So for a period of time, I started taking CBD oil, and after about 2 months, able to completely straighten my elbows, and everything, the inflammation went down. Because every time it was getting inflamed and I kept trying to push past it, it was causing more inflammation, right? So like you said, break that chain. I've since stopped taking the CBD oil. Still feel the pain, but at least I have full mobility in the elbows. So I wasn't sure how to adapt any of those strength exercises. I just did my back, right? And we're doing those, really strong. And I can see or feel, as you're pulling down, your arm is kind of rigid according to the tool that you're using and the weight training tool, but that some of those positions are really uncomfortable.
So elbows, some things about elbows. You have 3 joints in your elbow. They can get a little bit irritated. Mobilizing them that way you get good mechanics helps. One thing to think about a joint. If the joint is built to move and seed just so, it's wrapped with a thick leathery capsule that acts a little bit like the memory that guides the property about how the joint walks around and surfaces. If you irritate something and it swells, the joint property changes. So instead of having it walk nicely, the joint might tip and bind a little bit, and you'll get inappropriate contact between the 2 surfaces, and you won't be able to go further. And if you try to go further, it just tips and binds more, and you irritate the joint, swelling persists. A lot of making joints move better in general has to do with improving the way that joints roll and glide. One thing that happens at elbows is this idea of coupled function. So if you're running into shoulder issues and elbow issues, there tends to be a big correlate between tennis elbow and external rotator recruitment. And that's because your brain's usually oriented around getting a task done. So if you think about moving your arm to the side, your brain just thinks, get your hand to here. And if my shoulder can't do it, my wrist helps a little bit. A lot of times when people are running into elbow issues, when they're moving their shoulder around, they tend to have a lot of coupled motion. If you are doing certain motions and you realize you move your wrist a certain way every time you try to move your shoulder a certain way, practicing doing those 2 things separate will help to break apart that motor pattern, and you'll get less wear on the elbow. Some of the other stuff with elbows is mobilizing your forearm compartments. They get really, really tight. If your compartments get irritated or restricted at certain points where a nerve needs to be able to glide, you're going to protect the nerve, and you're going to carry tone in the muscle in a way that tends to beat the muscle up in an effort to protect the nerves. In your elbow, the nerve that runs around the outside of your arm is a radial nerve, runs through here down to these 3 fingers. It tends to get a little bit irritated with the coupled motion of pushing your hand out and wrist extending, and that's because we're just made to push your elbow out. Where the nerve leaves your external rotators and get pinched between those 2 tendons, when it comes down, it's supposed to go through the back part of your forearm. If you're getting squeezed at both ends on that nerve, then you tend to carry too much tone in those muscles. They may not relax during phases of lifting where the muscle should relax. The tendon gets a little bit irritated and can deal with additional inflammation. If you have good luck with the supplements, that's something I hear consistently from clients. The other thing is just improving general mechanics in the shoulder and the elbow. There's little stuff that can get restricted that change the way that the 2 bones will articulate at the elbow, and freeing up one joint can help. Sometimes if it's from a fall, the joint can either seed too close and get stuck that way, or sometimes joints can get seated too far apart and stuck that way. I've worked on people where their radial head is a little bit displaced. Their elbow functions fine, it just hurts. And that's just because things are offset. And once you approximate the joint, the strength comes back, things are a little bit better. Whenever joints deal with dysfunction in an effort to protect itself, it's that word I said earlier, arthrogenic inhibition. So if something's going funky, the muscles are going to change how they contract. If muscles can't hold the contraction appropriately and they kind of squeeze, give up, squeeze, give up, squeeze, give up, that's a way to make tendonitis onset and to perpetuate. Tendons don't like it one bit. And improving either mobility around the nerve, mechanics around the nerve, and mechanics around the joint can really help with consistent tendon pain. Hopefully, does that help a little bit?
It does. And there's times when that joint does lock up and you're just, like you said, you're just trying to like free it, that you can tell something is wrong. It's probably a good time for me to see a physical therapist there about that.
Yeah, and hunt around. A lot of it is everybody's got different styles. Everybody's got different body parts that they're good at. Everybody has different conditions at specific body parts that they're good at. So if you go to one PT, you try once or twice, it's not working. Just look for a different one. It's a big profession. It's incredibly broad with a lot of different styles.
Yeah,
Okay.
and Kyle was leading me down the rabbit hole of the difference in sort of academics and the programs and stuff that every clinician comes out of, including PT. And so all are not created equal. You all have a a very good one in front of you, but not all are like Kyle. Mackie did have a question, and then I know we have to end because we're over, but she's a bilateral below the knee amputee, and she had questions about, she just wanted to know some more information for double amputees. And I would say, based on listening to Kyle, everything is applicable minus the foot stuff. But are there any additional considerations you could think of, Kyle, with a bilateral, either BK or AK, as it pertains to additional concepts? For me, just riffing, I would imagine that you are sometimes less ambulatory than someone with one leg, just because it's a little bit more additionally taxing. And so there might be more seated positions that you're in throughout the day. And if that's the case, there may be some psoas work or anterior hip work for stretching, but that's just me riffing. Kyle, you are the expert.
If you're dealing with that, I would say just watch your back. In an effort to become stable, especially if you're learning early on to walk on bilateral prosthetics, you're going to crank into extension because you're off balance. And because that old adage, like perfect practice makes perfect work, or I don't know, am I saying the right way? How's the adage go?
Close.
However you practice it, that's going to be what happens. So a lot of these early movement faults that we develop from early learning on how to balance on new legs, they're going to perpetuate. You might not notice. So protect your back. Try to stay strong, your abs, stay strong in your hips.
Core work for sure.
Yeah, lots of it. Whatever assets that you have available, make sure that they're as strong and well taken care of as you possibly can. Hopefully that helps.
Yeah, awesome. Well, thank you guys for spending your evening with me. Your most valuable commodity is your time, and I'm so pleased that you continue to show up at these meetings and learn stuff that makes you better, and hopefully you can share it with other people. We'll have this available on our YouTube along with all of our other heart-to-heart videos, so if you guys want to check out our arsenal, you can subscribe and get alerts so you can see what new stuff's posted. Kyle, so grateful as always, and hoping that I see you Sunday. And I look forward to an upcoming PT session with you because it always makes me better. So you guys have a beautiful rest of your evening, and I hope to see you back same time, same bat channel next month. Have a good night.
Thanks so much.
Thank you for having me. I appreciate it.